Welcome to Healthcare by the Numbers, a podcast that uncovers what's driving healthcare transformation. Join us each episode as Caravan Health, now part of Signify Health, industry experts interview the brightest minds inspiring healthcare innovation and discuss the numbers which have shaped their thinking.
Well, welcome everyone. Greetings. I'm your host, Patti Schnieder, Vice President for Business Development at Caravan Health, which is now part of Signify Health. And I'm pleased to be hosting the Healthcare by the Numbers podcast live here in not quite sunny San Diego at Caravan Health's 6th Annual Accountable Care Symposium. So today I have the pleasure of being joined by someone I consider a colleague and a mentor, Anthony Esgro. Anthony is a PharmD who serves as Caravan Health's 340B Program Director. Welcome to the podcast, Anthony.
Excited to be here. Thanks, Patti.
Glad to have you. So really on this podcast, I think Anthony and I would like to frame our conversation with some of the numbers that are impacting the 340B industry. Specifically, we're going to focus on the savings that the Caravan Health ACO clients have been able to gain by optimizing their 340B programs. On average, we are seeing Caravan Health's clients realize a gain of about $200,000 in annual 340B savings by utilizing our program. Those are dollars that would have gone uncovered previously. And really, we know anyone that's been in the industry understands that covered entities and safety net providers rely on those 340B dollars for a plethora of services that are provided to patients in their community. So with that in mind, let's go ahead and dig in a little bit and walk through some of the things that I think folks would like to know about Caravan Health and our program. So Anthony, could you talk about our services at Caravan Health and then really explain how that might be different than the 340B TPAs are able to provide in the industry?
Absolutely. So Caravan Health offers what we call referral services or capturing. What we're able to do is assist the customer finding claims that they normally wouldn't capture from their current TPA. The reason we're able to do this differently than other TPAs is we have access to our customers' ACO claim data. So we get pure, clean data from the ACO for all of the members. This is easier to identify those patients because when you have a TPA working a claim, they have to identify patient's first name, last name, and do an algorithm to make sure that they know that, hey, Patti Schnieder is Patti Schnieder. Well, if you had the insurance ID number, social security number, something unique to that patient, you wouldn't worry about name, date of birth, and things. You'd have an ID number that's unique. Caravan has that unique number in the ACO data, the Medicare Beneficiary ID. That allows us to work with the TPA to find additional claims that would normally be missing. So for example, we can see where the patients that are attributed to that ACO entity, where they're traveling through the life cycle of the pharmacy. I think we all realize that in today's environment, PBMs mandate us to use mail order after the first 2 or 3 prescriptions. Mm-hmm. So what happens is, an entity may have a heat map and say, oh, the e-prescribed data is showing all this revenue going to John's Pharmacy. Well, when they start going live with John's Pharmacy, the revenue may not be as expansive as they thought because the patients are requiring to go to mail order, whether it be a Credo, Optum, any specialty pharmacy. So we help tie that data back and provide the customer with opportunity reports that say, hey, you may want to contract this pharmacy. The second advantage we have is seeing who those referral providers are. The biggest issue when it comes to identifying a referral claim is making sure that the TPA has that referral claim in their queue. And what I mean by that is a lot of pharmacies will not release data unless they know the providers related to that entity. We're able to see all of the individual providers that patient went to. So we work with their TPA to add those providers to their list to make sure that all the claims are in the queue as much as possible. And that's really where we differentiate ourselves from a TPA. Also the fact that we have unique proprietary software inside of our coach platform that allows us to fax notes, receive notes back, and then load into the customer's EMR so they have the care coordination notes to pass a HRSA audit.
That's great. Thanks for the kind of really kind of detailed explanation. So taking that a little bit further, I think a lot of people out there, including myself before I joined Caravan, were thinking, 340B, Caravan Health, isn't Caravan Health a Medicare Shared Savings Program, ACO provider, so to speak. Are our services at Caravan Health only for ACO members, or how could we help somebody that maybe is a potential client that isn't in a Caravan Health ACO?
So we certainly have an advantage by having our customers in the ACO because of the data that allows them to contract with new pharmacies, to see these additional claims, and to populate the queue. They don't need to be a customer of our ACO. If they still want our services, our referral services, which is us going into their EMR with read-only access, working their TPA fallout claims, we can certainly do that. But we tend to see that the customers benefit more greatly when they're part of the ACO because we're able to identify those provider who are the referral providers. So basically, when that provider works at, let's say, Cardiology of San Diego, you may only know 3 of those providers, but they can leave, you can get new ones, and we can see those different patients, seeing those different providers, and let them know who those referring providers are for that organization.
Awesome. So would, with respect to the referral prescription, are there cases where there is that kind of synergy between that referral prescription and that information that we're getting and how that might tie back to, the quality metrics at the level of the ACO? And could you explain a little bit about what that looks like?
Yeah, absolutely. So I think this what happened on our panel yesterday where Jill had mentioned, as she was looking through for the referrals, she noticed that a patient hadn't had a wellness visit. And we can see that the patient's going to a referral provider but has not been seen by the primary in the last 12 months. Well, that goes to our population health team, who then works with the customer to make sure that that patient gets called and contacted to come back in. So it's closing that loop, which is helping everybody. Having those notes, the referral notes on file for what the patient's taking really helps the primary understand the full care of that patient.
Thank you. That's great. Yeah, I've seen that and heard about that quite a bit from our clients. So I think it's important to note that to everyone, that kind of synergy and that dance between the ACO and 340B. So pivoting just a little bit, kind of taken away from talking about specific to Caravan Health Services, Anthony, you and I both know we've been doing 340B for a while.
Too long.
Yeah, right. There has been a lot going on in the news. So there's a lot of back and forth between the courts, the states, certainly drug manufacturers on 340B discounts, especially related to the contract pharmacies. So could you give kind of the highlights of where that stands today and kind of what your personal take is on it? And I don't know, you might want to even crystal ball it and say, what's it going to look like in the future if you could?
So it's been a slowly large snowball growing, mainly attacking the hospitals, the manufacturers, removing 340B pricing. Besides just one contract pharmacy, which is usually their owned retail, federally grantees have gotten a little bit easier in terms of the impact since the requirements aren't affecting them as greatly. What we have seen, a lot of our customers are now registering with something called 340B ESP to either recognize one pharmacy to submit the data to, or to share data and enable additional pharmacies. Whether they feel as though this is the best option, a lot of times it's driven by one, patient access to medications and taking care of their patients, that they feel as though they have no choice but to do this, and secondly, the lost financial revenue, which is impacting other programs. Where do I see this going? Well, I see health systems registering more contract pharmacies if they can, because normally they would have a threshold that says, hey, if I'm not going to make this X dollars, the audit responsibility and all the admin work isn't worth it. But we're seeing now that anything that they can find that's valuable, they're taking the risk. So now they become a larger potential HRSA risk, because normally they'd have maybe 20 pharmacies, now they're going to have 60, which creates more burden on the TPAs and everybody else, because there's going to be more pharmacies participating in the program. Where do I think it's going? Well, we all know it's in court now. You would hope there'd be some kind of happy medium to where, if the true issue is duplicate discounts, finding a way. I mean, I always think of, Oregon and what they do in just identifying the claims and sending a file to the state, that they then remove the claims from the Medicaid rebate is a great way. This is slightly different, but I think there should be something that everybody works on amicably to come to a fair agreement to make sure that patients continue to get served.
That's fair. It sounds like, too, with that, with respect to everything's going on, is why we also are seeing a rise in our clients and potential clients wanting to know more about the referral services, because the contract pharmacy piece is being impacted. So where are you going to make up those dollars? Do you agree?
Oh, yeah. I think we can both say, 5 years ago, anybody who was doing referrals was probably ahead of the game. And now everyone's trying to, if they aren't already, catch up, because that's just additional, what we'll call low-hanging fruit potentially, in closing the loop. And now with HRSA being challenged on the patient definition, it even opens up more potential from the referral standpoint. But a lot of these entities, outsource specific, specialties which have high-cost dollar drugs, and they are entitled to capture those. So everybody should be doing it, or at least looking into it. Because it doesn't hurt them. I mean, there's, especially in a Caravan program, there's no cost to start it up. So if they win, then we win. If we don't find anything, no harm, no foul.
Right, but we're really closing that loop, which I think is important, even from the, like I said, the quality measure. So you mentioned specialty drugs or specialty prescriptions. With 340B, I mean, are we seeing that people are using, generic drugs at all in the 340B, or what about the specialty medications? Like, kind of give me a flavor. Is where our referral program and what we're looking at, is it focused more on the specialty drugs and then kind of a little bit more ROI with respect to that?
So I think that depends on what you define as a specialty drug, right? So is a specialty drug written by a specialist? So is something like Eliquis for your heart by a cardiologist, is that a specialty? Or is it something like Humira where it's, for rheumatoid arthritis, is it a specialty? So we really focus on every prescription that would meet the business rules of their pharmacy service agreement, and how they're working with the manufacturer, whether or not they're allowed to include that claim in the program. And then from that point, we look at the claims with the biggest potential spread to them, and then work backwards, because they want to get their biggest bang for the buck, which makes a lot of sense. And it's a lot of work making sure that you close the loop in terms of that. Yes, a majority of the prescriptions dispensed are generics, but as we know, most of the programs do not allow generics as part of the program. So if it's eligible, we'll certainly look at it just like any other brand, but generally, from what we've seen with all of our customers, it's usually brand-only program.
Okay. Yeah, I know yesterday at one of the panels too, Jill, a PharmD was talking about, how she's really digging into those specialty drugs that are a certain dollar volume. And of course that's somewhat because she's doing a lot of this herself, as opposed to what we're actually able to do for clients, which maybe would open up kind of the number of prescriptions that we could look at versus only a certain threshold from a dollar standpoint.
I'll say the first, during implementation, the first 90 days is always the most claims to evaluate, because you have patients who've gotten 3-month supplies and they come in during those 90-day periods. But once you get those sifted through and you're able to qualify the claims or reject them, chances are that claim's never going to become eligible. But if it is eligible, then it's not going to show up in the queue anymore, because it's going to be captured for all future refills. So then about month 4, you start having a regular known quantity of claims coming in that we can work, and our team is pretty good about clearing out all of our customers' queues every month.
Great, thank you. So, seems like we've talked about COVID for the last couple of years. We definitely know that health systems, a lot of our facilities are being impacted. So do you think that whole situation has had an impact on the 340B drug discount program, and kind of how has that affected it?
So I think the pandemic has been really put the health systems into a pinch, because a lot of the manufacturer restrictions happened while they were all short-staffed, while they're dealing with the influx of patients coming in. What's happening now is these patients aren't getting access to the medications that they once had, because pharmacies happening to close or not be open, delivery services need it. So it's had quite a profound effect on the customers, from just patients accessing the medication to having enough staff. As we know, nurses are hard to find right now, and a lot of them are going traveling. So the patients, they don't have the same time they used to work the 340B program, and it's really unfortunate. And if I have my crystal ball, I hope monkeypox doesn't do anything that in the world today.
Right. Yeah. It's definitely it's an ever evolving world in 340B, and can be complicated, but I think both you and I kind of find some joy or fun in the complicated world that is 340B. Yes.
Well, yeah, I think it's fun when you help the customers. I mean, we have a few customers who we helped just the other day, register on ESP or provide additional pharmacies. And like you said, most are seeing over $200,000 a year, which is a lot of money. A lot of our customers are smaller rural hospitals. So, them getting even $100,000 is a big difference, where some of our larger ones are getting 200. A lot of it's just to deal with where their pharmacies are located and whether or not they have provider-based clinics. But it's a big difference to them, and they really appreciate what we're able to do for them on both sides of the referral and closing the loop for those patients.
Yeah, and I know you have, it's been a pleasure to have you as integral, kind of leading the charge at the Caravan Health. You're even doing a little bit of maybe what I would consider consulting work for some of our clients, just because, like you said, they are short-staffed. There is a lot of confusion about the program. They may not have the people. So tell me kind of some of the things that, kind of outside the box that you're able to do.
Yeah, so we certainly want to help our customers in any way we can because, it certainly drives value back to the ACO if they're part of it. So everything that we can do to help them from a pharmacy standpoint or from a healthcare standpoint, we want to do. So, by adding additional pharmacies, working with the TPAs, to helping them understand the manufacturer impact. What we've seen a lot of is everyone has what they would call a 340B coordinator, somebody responsible for the program. But those type of jobs have been turning over a lot during the pandemic as well. So bringing someone up on 340B is very difficult because of all the moving parts, and it's probably gotten even twice as difficult with all the manufacturer restrictions and the nuances. So, most of our customers are dealing with not one, not two, but 3 TPAs because you have your primary, you have your well partner if you have CVS, and then you have Walgreens if you have Walgreens. So it's a lot for someone new, and we certainly try to coach them up and help them as much as possible by having standing, bi-monthly or monthly calls that certainly show what we're doing, but also help them to navigate what their TPAs are doing and make that a really good working relationship.
And the last thing I really kind of wanted to touch on, if you don't mind, could you perhaps explain a little bit about, compliance is so important, right? We know that nobody wants to have a HRSA auditor sitting there next to them asking about the 340B program. I think it'd be great for people to understand, what we're doing to make sure that we're mitigating that risk for them from a compliance standpoint. So could you talk a little bit about that?
So part of the implementation process is to understand the eligible locations, so a mapping template of where their eligible locations are from either the provider-based clinics or their hospital organization. Secondly, we go into and get a provider file, understand where that's coming from. But then inside of our platform, Coach, we work with their policy and procedures to make sure that it's updated for how we're going to work the program and how they're going to audit or for our referral services. And then in Coach, it really lets you know each of those claims and has a trigger that says, hey, this patient has to be seen by them before this date in order for us to even approve the claim. So if that criteria is not met, our platform will just reject the claim until the dates align. And then we can take that note and just pop it into their EMR so that way they have it right there on the patient's face sheet should HRSA come in for an audit.
Great. And it sounds like, though, that, and I, of course, know this, but I think it's important that the folks listening understand, even though we can do all this in Caravan Coach and it's a full service model, they still have oversight, right? So somebody sitting in pharmacy or someone is still going to be looking at those, potential RX claims and approving then to move on to the TPA. Yeah,
we actually have two kind of processes. One is where we'll meet bi-weekly or monthly or even send the file of what we approved. Say, hey, take a look at this if you want. Some say, we trust you, we've done this enough, you just go ahead and do it. Others want to see the claim. So we have both options on the table. It's really client specific, but most prefer that we will just do it for them and then they'll see it come back and it's just less burdensome for them. They just want to audit it after it's been captured.
Great. Well, I really don't have a lot of other questions to ask you today. It's really been a pleasure being here as the host for Healthcare by the Numbers, but I want to kind of give the last final words to you. Did you have any final thoughts or comments, Anthony, that you'd like to make?
No, I think this was great, and I hope our audience enjoys this, and they can always reach out to us because we certainly want to help them get as much possible savings/revenue they can to assist the patients in their mission.
Great. Well, I thank you very much, Anthony, for being with me today. And for all of you out there listening, thank you very much. It has been Healthcare by the Numbers. And until next time, be well and take care.
Thank you for joining us today. You can find more information and episodes on the show's program page on Healthcare Now Radio. Follow the show's hashtag HCBTNPod. We are Caravan Health, and this has been Healthcare by the Numbers. Until next time, take care.